lady and recognizes gentleman Mr. Roy for 5 minutes.
Chairman Pitts, Ranking Member Pallone, and members of the Health Subcommittee.
Is your mic on?
Let's see. There we go. Chairman Pitts, there we go. Ranking Member Pallone, members of the Health Subcommittee, thanks for inviting me to speak with you today about IPAB. My name is Avik Roy, and I'm a healthcare analyst at Moness, Crespi, Hart & Company, a securities firm in New York. In that capacity, I recommend healthcare investments to our clients who represent the largest investment firms in the world. In addition, I'm a senior fellow in healthcare at the Heartland Institute, in which capacity I conduct research on health policy with an emphasis on entitlement reform. In my remarks today, I'll focus on 4 questions. First, why is Medicare so expensive? Second, what's the best way to adjust the growth of Medicare spending while preserving high-quality care for seniors? Third, is IPAB likely to aid these goals? Fourth, is IPAB perfect as it is? Is it possible to reform or improve IPAB? Or should Congress scratch the whole thing and try something else? Why has Medicare spending gone through the roof? Many trees have been killed in search of answers to the question. But while there are many plausible drivers of Medicare's spending growth, the single biggest problem is this. It's easy to waste other people's money. It's like the difference between a cash bar and an open bar. At a cash bar, I might order a beer or a house wine, but at the open bar, I'd probably ask for a fine Kentucky bourbon, especially if Congressman Guthrie and Whitfield come back. Price becomes no object in such a system, and Medicare is more like that open bar. As a result, seniors tend to be entirely unaware of how expensive their treatments are and have no incentive to avoid unnecessary or overpriced care. Studies show that spending has increased most rapidly in those areas of health care where individuals bore the least responsibility for their own expenses. So what should Congress do? There are 3 ways to deal with the Medicare cost problem. The first, which is what we do now, is to avoid hard choices by promising that we'll cover nearly every treatment, but underpay doctors and hospitals in compensation. The second approach, which we call rationing, is for Medicare to determine, either by congressional order or an expert panel, that certain treatments aren't cost effective and deny them to seniors who seek them out. The third option would be to let seniors decide by granting them more control over their own health dollars, either by increased cost sharing and or by allowing them to choose between different insurance plans with different benefit packages. Our current approach, underpaying doctors and hospitals, is leading more and more doctors to drop out of Medicare. We already see this problem in Medicaid, where internists are almost 9 times as likely to reject all Medicaid patients for new appointments than those with private insurance. According to Medicare actuary Richard Foster, Medicare reimbursement rates will become worse than those of Medicaid within the next 9 years. And studies show that health outcomes for many Medicaid patients are worse than those who have no insurance at all. As you know, after objections that rationing care through IPAB would resemble a death panel, Congress severely constrained IPAB's authority, preventing the board from including any recommendation to ration care, raise premiums, increase cost sharing, restrict benefits, or alter eligibility requirements. I know that you are all very familiar with the endless tussle over the Medicare Sustainable Growth Rate, or SGR, which has caused significant fiscal headaches because Congress routinely overrides the SGR's requirements for reduced payments to doctors and hospitals. But IPAB, as it's currently designed, is similar to SGR in that its primary approach to cost control involves reducing payments to physicians. These global reimbursement cuts haven't worked in the past, and they won't work in the future. Hence, we should be seriously concerned that IPAB, as it's currently designed, will reduce seniors' access to doctors and healthcare services, thereby worsening the quality and outcome of their care. So the question we must then ponder is, can IPAB be fixed, or should Congress wholly repeal it? It's conceivable that a differently designed IPAB could help Medicare spending more efficient. For example, an IPAB that was empowered to make changes to Medicare premiums, cost-sharing provisions, and eligibility requirements could assist Congress in enacting much-needed reforms to the program. I know that both IPAB's proponents and its opponents see the board as a foot in the door for government rationing. But let's remember that, for 45 years, we've misled the public into thinking that we could provide seniors with unlimited taxpayer-funded health care with no constraints. IPAB, to its credit, is an attempt at intellectual honesty because government rationing is the logical and necessary consequence of single-payer systems like Medicare. Between IPAB and the 2012 House budget, Congress can now have an honest debate. Should we move to a more British-style system of rationing under single-payer health care? Or should we move to a more Swiss-style system of individual choice and diverse options? In the diversity and choice approach, if you don't like how your health plan restrains costs, you can switch to another plan or spend your own money on a more generous plan. In the government-driven approach, you have to accept what the government tells you to accept or pay onerous economic penalties. It's certainly my view that diversity and choice is more appealing and also more likely to work. Thanks again for having me. As an addendum to my written testimony, I've included an article from the latest issue of National Affairs in which I further expand on these issues. I look forward to your questions.
Chair, thanks you, gentlemen. Thanks you, gentlemen. I'll now begin the questioning and recognize myself for 5 minutes for that purpose. Mr. Roy, changes that reduce cost by improving the health care delivery system and health outcomes often require several years before savings may occur and the board may have to find immediate savings. Therefore, isn't there a real concern that board proposals may skew towards changes in payments which are likely to result in de facto rationing of care and ignore the more important aspects of long-term reform?
In fact, it appears that that is almost certain to be the likely consequence of IPAB's decisions.
Thank you. Okay. Chair recognizes Ms. Schakowsky for 5 minutes for questions.
I thank you, Mr. Chairman and Mr. Pallone, for letting me go out of order. Mr. Roy, I have to say that I am deeply offended by your open bar analogy. It's like saying, oh, honey, now that we're 65, I can get breast cancer and you can have that heart attack. And we are now able to get, I can get a PET scan and an MRI and a CAT scan, as if older Americans are making those kinds of decisions. Or, as I think Dr. Gunderman pointed out, as if they're making those decisions differently from people who have insurance who also go about their business knowing that they're insured and get the health care. I mean, really, I think this idea that, and also that Medicare has exploded. It has not, in fact, exploded more than health care costs in the private sector. Is that true, Dr. Fetter?
That is true. That is true, Congresswoman. That Medicare spending per capita grows more slowly than the private sector.
More slowly. The other thing is, you must not have seen the recent Medicaid study, a scientific study done out of Oregon that absolutely showed, the first actual scientific study that was able to take 10,000 people who got Medicaid, 10,000 who did not, and had profound improvements in the health care of people. You ought to check it out. It's a very important important study. So I think that it's insulting to older Americans to say that now they're just spending their days just having a great time at the doctor. Mostly I think people are trying to figure out how to, perhaps have a little vacation or something, or pay for their medications is more likely. Dr. Fetter, what you're saying in your testimony is that because the problem is system-wide, that and you mentioned how consumers should have choices and mentioned Switzerland. Switzerland says in the basic package, insurance companies can't make any profit. Did you know that?
Yes, they're nonprofit companies.
They're nonprofit companies. That makes a rather big difference between the U.S. system that anyone has proposed and the Swiss system, which I think was sort of glossed over in your saying that we should have more. I think I'd like that. Would anybody want to comment on the issue of access to care? Is it really a concern that and I'll leave that to that if Medicare reimbursements are too low as a result of a decision by IPAB, that doctors simply won't take Medicare patients.
That's already happening. So if you look at consistent surveys, the rate of the difficulty for Medicare beneficiaries gaining access to care is higher than it is for people in private insurance.
Actually, I saw an opposite study. Maybe you haven't seen a more recent study that has 93% of Medicare patients were able to access care as opposed to 88% of people who had private insurance.
The consistent consensus of all the data is that Medicare, access to care for Medicare beneficiaries is worse, and I recommend that you talk to the physicians in your district, and I think they'll agree.
Let me just say on the issue of access to care, Mr. Roy, I have talked to the doctors in Janikowski's district, and they tell me to a man and a woman that they are in deep trouble because they cannot afford the cost of delivering their care. Now, true enough, MedPAC came to this panel, I think it was in the last Congress, testified to us that there were not access issues that they had identified, and then Glenn Hackbarth has visited me since then saying he is becoming concerned about people, particularly seniors who move, and when does that happen? Oh, I want to be closer to the grandkids. So they move to a new city or location, and there they find the door is closed. And if this Congress continues to bury its head in the sand about that, we're going to find that the world becomes very, very hostile. Now, Mr. Roy, let me just tell you, I was not offended by your open bar analogy. I do not drink myself, but I thought it was apropos. And, you know, the President of the United States, when he had the Republicans down 3 or 4 or 5 weeks ago to the White House, big reception in the East Room, and he wanted to drive a point home with us. And I think the point he wanted to make was that drugs cost too much. But the point he made was that during the, and it's not a HIPAA violation because he told us in an open forum, in the election, he developed a rash on his back. And he was concerned about it. So we went to a doctor who's prescribed some goop to put on it. And he put the goop, he didn't use the word goop, I made that up. But he put this cream on it for the prescribed time. And it might have helped a little bit, but not so much. So he had it refilled. He had a little prescription card. It cost him $5 to get it refilled. So we went down and had it refilled. And then he was on the campaign trail, and he ran out. So what to do? He went to a pharmacist, explained to the pharmacist his dilemma, got the prescription transferred via the miracle of electronic records, and the pharmacist bagged it up for him and said, that'll be $400. And the president looked at the pharmacist and said, you know, this rash is not that bad. And at that point, the president became an informed consumer and was spending his health care dollars wisely. Now, people do argue that, well, wait a minute, you go into that sort of system and people will not get health care when they need it. He also pointed out to us, and I did not know this, but apparently one of his daughters was gravely ill when she was very young, and he went to the emergency room with her, and the doctor explained the diagnosis and what would have to be done and what he proposed. And the president, then not the president, but he said, do whatever it takes. And of course he did. He behaved in a rational fashion that you would expect, what you would expect a father to do when their child is gravely ill. He did not question cost. So I guess the point I'm trying to make is the president actually articulated a strategy for consumer-directed health care that I thought was phenomenal for him to admit. Now, we had some hearings leading up to the Affordable Care Act. We didn't have hearings that I thought really would have gotten to the issue of the cost of delivering care. If we were serious about that, we should have invited Mitch Daniels in here and said, how did you do it with your Healthy Indiana plan? Now, Dr. Fader is saying that the cost of Medicare grows more slowly than other areas. I don't think that is accurate, and I'd like to hear Dr. Gottlieb and perhaps Ms. Cohen weigh in on that, and you too, Mr. Roy. But we never heard from someone who is actually making it happen on the ground. A Healthy Indiana program cost went down by 11% over 2 years. So even if we accept the figures that I believe are wrong that Dr. Fader is talking about, why wouldn't we do something that's even better than that, which was look into consumer-directed health care? Because as the president so correctly articulated, something magic happens when people spend their own money. Now we're left with this independent payment advisory board that's going to tell us how to magically spend less money. And it just takes me back to a speech that Ronald Reagan gave in 1964. And he talked then about some of the issues that were ahead and whether or not this country still believes in its capacity for self-government, or whether we abandon the American Revolution and confess that it is a little intellectual elite in a far distant capital that can plan our lives for us better than we can plan them ourselves. Ronald Reagan was describing the Independent Payment Advisory Board. I've gone on too long, but Dr. Gottlieb, do you have an impression as to whether or not the cost of delivering care is rising more slowly in Medicare than in other areas?
Refer to Mr. Roy on
Very well.
analysis and numbers. I haven't seen any apples-to-apples comparisons on senior care because everyone's in Medicare. So
That's correct. So you can't really analyze the numbers directly because seniors, of course, are almost all in Medicare, not all of them. But and they're also over 65, so they have higher medical expenditures.
Well, let me ask you a question. Regardless of whether you're a for-profit or not-for-profit insurance company, you need to have access to capital. So the cost of that capital is what the cost of the capital is on the open market. But does Medicare have a cost of capital that they have to put on their balance sheet?
No, in fact, there are a number.
Do they have a cost for advertising they need to put on their balance sheet?
There are a number of different aspects of Medicare administrative costs that are off the HHS or Medicare.
And on that general administrative side of the balance sheet, what about all of the administration that goes on in the Department of Health and Human Services that is appropriated through a discretionary appropriation, which is the largest appropriation that occurs every year that the Congress deigns to do appropriations bills?
That is
I would just add, the most significant cost of Medicare is the cost of compliance with the Medicare program, which is a cost that isn't estimated. If you look at what goes on in medical practice, a good percentage of the expenditures in any medical practice or in the hospital is on trying to comply with the Medicare program because of the threat of, a Justice Department audit or a Medicare audit. Hospitals, medical practices overspend on that. That doesn't get calculated in the cost of the overall program, if you will. Private health care plans have to actually hire staff to do that kind of work. Medicare can just foist rules on the private sector and back it up with the threat of litigation or criminal penalty, and those costs don't get estimated in the cost of the program.
Very well, thank you.
roughly speaking, the administrative costs per double when you count all the off-budget expenditures of Medicare, and that doesn't also include the cost of fraud, which is very significant in the Medicare program relative to that for private insurers. If you add all that up, the administrative cost per beneficiary for Medicare between fraud and the actual administrative costs is arguably double to 3 times that of private insurers. If you leave fraud out, it's about 20% higher.
Thank you. Thank you all for being on the panel today.
I'd like to get Mr. Roy's opinion on that same thing, if he can.
I think that I would echo Dr. Gottlieb's comments. I think that the importance of access to a physician cannot be understated. It's the most important thing. If you have a problem and you can't see a doctor for that problem, and that problem festers, you could have a much more serious medical condition. Children die of toothaches on Medicaid because they can't see a dentist and have their abscesses removed. There are serious, serious medical problems and problems of health care that if you can't have access to a physician, you can't do anything. So the fact that the IPAB is explicitly restricted from changing the mix of benefits really doesn't matter if somebody can't actually see a doctor in the first place.
Right. Well, I thank you both for that answer and that question. I've got one more, Mr. Chairman. Secretary Sebelius, in her statements today, said that the administration has begun outreach efforts to fill these 15 seats on the Independent Payment Advisory Board. I'd just be curious to know, among this distinguished panel, whether or not any of you have been contacted, and I'll very specifically ask Ms. Cohen, has anyone from the administration contacted you about serving on IPAB?
No, probably because I'm suing them.
Ms. Fetter, Judy Fetter, has anyone from the administration contacted you about this?
Well, I've actually had lots of discussions about various aspects of the Affordable Care Act with the administration, and indicated that I would be proud to serve on the Independent Payment Advisory Board.
So the answer is yes.
Not
that sounds like a yes to me.
Asked would be grossly overstated.
Yeah. I take that as a yes. Mr. Roy, how about yourself? Have you been asked?
I'm afraid not, and I like my current job, so I'm okay.
Dr. Gottlieb?
I have been asked by some Senate staff, and I indicated that I'd be interested in being nominated, but I wouldn't want to serve. My only reason for being nominated is I want to write an op-ed outlining why the president shouldn't pick me to serve on the board.
So the response, Mr. Chairman, is that 2 of our panelists have been at least approached and one is enthusiastic about the possibility of serving, and the other one is not. I thank you all very much for your response, and I yield back my time.
Doesn't deny care, and just like Medicare Part D, it's 40% underestimate because
No, Medicare Part D.
health plans have to compete. Anybody can answer. I'm just not asking one question.
Well, let me, if I may stay with you, I don't think Medicare Part D offers you the answer there, sir, and the cost of prescription drugs are rising as well. We need to make the system more efficient.
I'm about out of time.
Yeah,
I'm sorry. I'm sorry to cut you up. I only got 40 seconds.
No, I think that one of the things that we see with the CBO projections is the CBO consistently underestimates the importance of cost shifting in medical expenditures. So Medicare Part D has a significant cost sharing component, which is the donut hole, the so-called donut hole, which is now going away. But that donut hole is a big part of the reason, along with the choice in plans, that Medicare Part D has come in 40% under budget. Whereas with the conventional, traditional parts of the program, expenditures have skyrocketed out of control because there's been minimal cost sharing.
And the administration wants people making $250,000 or more to pay more taxes. But they don't want them to pay more for their health care. And what our plan does, if you're at the lower end, you still get covered. And as you have the higher end, you'd pay more. And so instead of a $250,000 a year person at 65 years old paying more for their health care, they're going to send the bill to my 17-year-old daughter and my 16-year-old son and my 13-year-old daughter.
I would make a point about that, which is that because medical expenditures grow at faster than the rate of GDP, you can never raise taxes fast enough to compensate for the rise in healthcare spending. So it's always much more efficient if you want to means test on the spending side rather than on the taxation side.
I am concerned about something you said, Mr. Roy, and because in the United States, either the government is subsidizing the payment for health care or the private sector is. But the individual consumer, and there is no other product or service that has that kind of status in this country that I'm aware of. But I am somewhat disturbed by the fact that it must be all of the patient's fault. And I'm concerned about some aspects of IPAB. I share the concerns of my physicians in my district that are saying, where will our input? How are we guaranteed that we have something to say as far as the information that's going to be considered by the members of this board? I am really worried about that. But where does the responsibility lie? I will tell you right now, if I go into my doctors, and I've been going to them for a number of years, and if they tell me I need a certain procedure or a certain test, I really don't question it. Now, let's just say I didn't have Blue Cross Blue Shield because it's employer-sponsored. I'm a member of Congress. But I was going to pay that out of my own pocket. I'm still not real sure. Your premise is that I'm going to shop around, and I'm going to go around and say, I'm not sure that I really need that test. I think I'll go and see another doctor and get another opinion, which is going to cost me money and such. So where's the responsibility lie? Do you believe that maybe the physicians have a responsibility only to provide that service, which is absolutely necessary? I'm not going to get into the argument of unnecessary testing and everything else, because I've got the gold standard in the state of Texas, and it has not brought down the cost of health care in the state of Texas. It has brought down the cost of insurance policies for certain specialties. So where is this shared responsibility? How do we get a handle on this? And isn't IPAB maybe a method of achieving that goal?
If one looks at a number of studies around the behavior of patients and physicians with high deductible health plans and health savings accounts, where there is more consumerism, where there is more ability to shop for procedures and tests and office visits, you see a lot more intelligent consumption. I think in Washington we have an excessively pessimistic view of the ability of individuals to make intelligent decisions about their own care. Especially in the days of the internet, people do a lot of research, people have a lot of knowledge. If we had a system where consistently, across the system, for everyone, there were more and more people who could shop for care, who bought insurance for themselves instead of having it provided by someone else, you have more of the ability to start thinking in the way that people need to think about, well, do I really need that test? And if the doctor says, yes, I really do think you need that test, even though it costs $2,000, the patient might say yes. But maybe the doctor will say, you know what, that test is $2,000. I think it might benefit you a little, but maybe it's not worth paying for you right now because it's $2,000 and you are very unlikely to benefit from it.
Don't you think the determining factor, though, really, in most tests, and I know this is going to be controversial, is whether it's covered or not?
Could you repeat the question?
What I'm saying is, Whether you have access to a number of tests or not is whether that test is going to be paid for through some subsidy, either through private insurance or government. Isn't that the truth?
Not necessarily, because again, if you have co-pays, deductibles, health savings accounts, and other mechanisms by where the patient shares in the expenditure, the patient has more of an incentive to monitor those expenditures and make sure they're being executed intelligently.
Mr. Roy, what would you, I think we know where Dr. Gutterman is going. What would be your thoughts?
Yeah, so I think you actually, Dr. Cassidy, bring up the most important point around this faulty idea that somehow Medicare expenditures are growing more slowly than private sector, because what happened is the Medicare shifts costs to private insurers. So if I have 2 Chevys that I paid $10,000 each for, and the government comes to me and says, I'm buying that one Chevy from you for $5,000, and I lose $5,000 on that, maybe I charge the other guy $15,000 to make it up, and that's effectively what cost sharing is. It's more complicated than that in reality, but that's basically what Medicare does. Medicare cheats by underpaying for care and restricting access, and these are the problems that unfortunately have a significant, are what IPAB is all about.
Dr. Gottlieb, what your thoughts, please?
Well, I think IPAB has no alternative but to try to squeeze payments in the short term, because anything I could do to try to fundamentally reform payment systems the way care is delivered isn't going to score well. CBO, they're going to have to achieve immediate savings. I think one of the larger problems here is that a lot of the reforms in the Accountable Care Act and a lot of things we're talking about here today are predicated on changing the delivery model, getting better coordination of care. Those require investments in innovation in how care is delivered. And the only way that providers, hospitals, doctors are going to invest money to better coordinate care is if they can earn an above market rate of return for a sustainable period of time on their invested capital. And the problem is that the administration's legislation and regulations don't allow for that. And that's why you're seeing the adverse reaction to the regulations on the accountable care organizations. I could tell you I've seen a lot of business plans floated with venture capitalists on creating new accountable care organizations or services that would provide services to the accountable care organizations. I haven't seen a single one get funded for that precise reason, that the presumption out there is you're not going to be able to earn a return on capital. If you do earn an above market rate of return on capital for any length of time, it's going to be regulated. If you continue to earn above market rate of return, it's going to be taxed. And if you continue to earn it after it's taxed, you're going to be criminalized.
But on the other hand, if you don't, you'll be subsidized.
And when it's gone, you subsidize it.
Now, and that is without saying that, again, as I mentioned earlier, the New England Journal of Medicine article that reflected upon the 10 accountable care organization pilot studies, places specifically chosen so that they would be more likely to succeed, did not.
With that, this has been an excellent panel. Thank you for the information you've shared. That concludes today's hearing. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to please agree to respond promptly to these questions. With that, the subcommittee is adjourned.